Great. Thank you, Michelle, and happy Pride, everyone. Thank you for joining today. I hope it's a great weather day over in New Mexico. I'm reporting here from the Northeast. Unfortunately, we're experiencing some good weather, so I hope the rest of the month it's a great time for you to celebrate Pride over in New Mexico. So today, Dr. Kano and I are going to be talking about cancer research in LGBT communities, and I'm going to start off by discussing some cancer care disparities within the community, and then Dr. Kano will transition to more research-specific topics. So overall, we're going to describe cancer-related disparities in LGBTQ communities, describe efforts to build the next generation of LGBTQ cancer researchers, and list resources for providers to become more knowledgeable in serving LGBTQ community members affected by cancer. So I'd just like to, you probably are familiar with a lot of the basic terms and letters included in the LGBTQ acronym, but I just like to always start at a baseline to make sure for any people that are maybe unfamiliar or forgot what the letters refer to. We'll just quickly go through this. So L in LGBTQ refers to lesbians. Lesbians are women whose primary emotional and sexual relationships are with other women. G stands for gay, often refers to gay men who experience primary emotional and sexual relationships with other men. Sometimes women use the term gay as well to describe themselves. B is for bisexuals. Bisexuals experience emotional and sexual relationships with both sex genders. And T stands for transgender. Transgender refers to individuals who feel an incongruity between their self-identified gender and their birth gender. You may have seen other letters included in the acronym, such as Q for queer or questioning, I for intersex, A for asexual, androgynous. A lot of times you see the plus now, just like as a catch-all. You may have also seen, particularly in peer-reviewed publications, SGM. So SGM stands for sexual and gender minorities, and that's another umbrella term kind of to capture different minority sexual orientations and gender identities. I think, for clinicians, what I tell trainees, it's most important not to necessarily memorize every single term or new term that, comes into practice, but, just ask a patient, what does it mean for them? And let them define it for themselves, because at the end of the day, that's really what matters. I think for research, right, it's more tricky, right? Research, we have to be a little more strict about how we define things. But it's important to ask research participants, in addition to patients, how they define terms for themselves. And a lot of times, for purposes of data analysis and aggregation, we can collapse a fair number of terms under a sexual minority or gender minority umbrella or category. So just an overview of where national representation in terms of LGBT identities. You see an upward trend over the past decade. This is a Gallup poll released in 2021, just showing an upward trend in national representation. You see a pretty swift uptick after 2017. When you look a little more closely, you see the largest representation within the cohort is amongst bisexual identified individuals, followed by gay, lesbian, and transgender. And then probably the greatest reason for this uptick in national representation is particularly amongst younger generations. So Gen Z and millennials disproportionately identify as LGBT when compared to their elders. Will this identification persist as younger generations age? I think time will tell. It's important to remember that in addition to sexual and gender identity, our patients have other identities or backgrounds that influence their access to care and their current health care. You may have heard the term intersectionality. It refers to, it's basically a framework for talking about oppressions and privileges that overlap and reinforce each other. So, if a patient identifies as gay, Latino, from New Mexico, they may face different barriers to care and then someone that is straight identified Caucasian from New York. Um, so various national cancer organizations have identified specific disparities within the LGBTQ community, including the Institute of Medicine and the American Society of Clinical Oncology. Overall, we've identified an overall lack or paucity of LGBT-related cancer research. There are elevated rates of cancer risk factors such as tobacco, alcohol, and HIV, which I'll go into more detail shortly. Lower rates of cancer screening within the community, for example, lower rates of cervical cancer screening for women who have sex with women, lesbians, bisexual women, lower rates of mammography as well. Lower satisfaction with cancer treatment has been documented in the literature. Higher rates of psychological distress and survivorship, and gaps in patient-provider communication. And training both our clinicians and researchers on best practices in clinical communication skills and research communication skills so patients stay engaged in clinical care and research is critical. So just highlighting some risk factors associated with cancer. So HIV is associated with specific cancers such as Kaposi sarcoma, anal cancer, non-Hodgkin lymphoma, et cetera. You're going to see different risk profiles in literature. Basically, the take home is that patients with HIV are at greater risk for developing the cancers listed below. And we know that HIV significantly impacts the LGBT community, particularly men who have sex with men and transgender women. This is just a snapshot of how, despite the fact that HIV's been around since the early 1980s or was identified in the early 1980s, the illness is still disproportionately impacting members of the LGBT community, particularly communities of color. And this is just a snapshot of CDC statistics from 2019 showing the disproportionate impact of HIV amongst communities of color. So for the clinicians on the call, just a reminder to make sure that you discuss HIV testing and safe sexual behaviors with your patients. Another risk factor for alcohol is alcohol use, and data has shown disproportionate reporting of alcohol use amongst LGB, specifically individuals in this graphic. You can also find this on the CDC website. So it's just highlighting disproportionate use of alcohol amongst LGB individuals when compared to their heterosexual peers. Tobacco use has also been cited to be disproportionately used by LGBT individuals. So nearly 1 in 6 LGBT individuals report smoking cigarettes compared to only 1 in 8 heterosexual or straight adults. Transgender individuals, a little over a third report using tobacco when compared to about a fifth of their cisgender peers. And why do we care about tobacco and alcohol, right? Tobacco puts you at greater risk for lung cancer, head and neck cancers, esophageal cancers, alcohol, liver cancer, and some head and neck cancers as well. I talked about earlier inadequate cancer screening, and this is just a graphic that highlights disparities in access to cancer screenings amongst LGBT women, right? You can see here lower access to cancer screenings for LGBT identified women for pap smears, significantly lower access to mammograms and colonoscopies. Looks like there's not a disparity there, actually slightly better. Other issues for women's health. So I mentioned access to cervical cancer screening. Historically, the idea was that lesbian and bisexual women are not at risk for cervical cancer compared to their heterosexual peers because they're not engaging in penile vaginal sex. But we know that HPV is transmitted largely through skin-to-skin contact. So digital contact, sex toys. The main take-home is that regardless of how a woman identifies, cervical cancer screening should be offered to them, regardless of their self-identification. In terms of breast cancer, there have been some reports of lesbians and bisexual women being at higher risk for breast cancer due to higher rates of nulliparity, higher rates of alcohol use, and higher rates of obesity. But there's still there's still no current national recommendations to start mammograms at an earlier age for women who have sex with women, lesbians or bisexual women. In terms of ovarian and endometrial cancer, again, for the same reasons as breast cancer, lesbians and bisexual women may be at higher risk for ovarian and endometrial cancer, but more data needs to be collected. And there are no screening tests currently for ovarian and endometrial cancer, but more research here needs to be done. In terms of men's health, particularly men who have sex with men, gay and bisexual men, I talked about HIV as a risk factor for cancer. Gay and bisexual men are also at higher risk for anal cancer, particularly HIV positive MSM. There's a greatly disproportionate risk of developing anal cancer for HIV positive individuals. There is a screening test called the anal pap smear, which basically is administered similarly to the cervical pap smear. It's basically a swab of the anal canal, and then a pathologist reviews the cells under slide for any signs of dysplasia or cancer. So it really just depends. Maybe your clinic or hospital can run the sample. It really is site specific. If your lab will process it, and if the patient's insurance will pay for the screening test. There is no national recommendation for anal pap smears for MSM individuals, but a lot of literature particularly recommends it annual or biannual anal pap smears for HIV positive MSM. So if your patient is HIV positive and MSM identified, warrants a discussion about an anal pap smear. Definitely if they're experiencing pain with defecation, bleeding from the anal canal, then it would definitely merit further investigation. I also put vaccinations here, and that's important for all of your patients, right? You want to ensure that they're up to date on their vaccinations, particularly HPV, to reduce their risk of cervical, anal, head and neck cancers, Hep B and hepatitis A, to reduce their risk of developing liver cancer. In terms of transgender care, transgender cancer care, screening is largely based on organs that are present, right? So it's important to take an organ inventory with your transgender patients and screen appropriately. So for example, for a trans man, if they currently possess their natal breasts and they're at the appropriate screening age, you're going to refer them for a mammogram, right, for breast cancer screening. If they've undergone reconstructive surgery to either remove their breasts or reduce their breast size, you're likely not going to be able to complete a traditional mammogram. So in that case, you may want to consider an ultrasound or an MRI of their chest, particularly if they have unexplained weight loss or skin changes or a mass concerning for breast cancer. For trans women, the current recommendation is any transgender woman who has been on feminizing hormones for at least 5 years. After 5 years of feminizing hormones, trans women achieve parity in terms of breast cancer risk when compared with their cisgender women peers. So trans women on at least 5 years of hormone therapy, you'd refer for a mammogram. Cervical cancer screening for trans men, again, if they've retained their natal cervix, you're going to refer for cervical cancer screening as appropriate. If they've undergone bottom surgery and they now possess a neopenis, right? Currently, the best practice is to perform a hysterectomy on all trans men pursuing bottom surgery, so there is no cervix to test for screening. Perhaps if they've pursued a surgery in a foreign country and it's unclear if they still have their cervix, you may want to perform a CAT scan or MRI just to just confirm their current anatomy. In terms of prostate cancer screening, so trans women, whether or not they pursue bottom surgery, the prostate is not removed during bottom surgery. So just keep it on your radar. There are currently no national recommendations anymore for PSA testing for men or trans women, but just keep it on your radar. Perhaps an annual digital rectal exam and some shared decision-making about PSA testing. We still need more research in the field, so more research on cancer risks for transgender individuals, impact of hormones on their risk profile, whether any gender affirming surgeries as well impact their risk of cancer. As I mentioned earlier with other cohorts, keep vaccinations up to date. And again, a reminder to screen all of your patients for HIV, particularly for our high-risk LGBTQ community members. This is one citation that just highlighted something I forgot to mention. So trans men can screen for cervical cancer using self-sampling kits. So some trans men feel uncomfortable going to a GYN clinic or primary care clinic for cervical pap smear testing in an office setting. So this is one option that you could potentially offer to your patient if they're very adamant about not coming to a clinic site for a pap smear. Research has shown that the self-sampling kits are a viable option. It's not perfect, and it's less than ideal. Ideally, you'd want them to complete pap smear testing in the clinic, but if they're adamant about not doing it, research has shown that the self-sampling kit is a viable option for screening for cervical cancer. Okay, so I'm gonna transition to Dr. Kano for a discussion about educating the next generation of cancer researchers.
Thank you, Nelson. Let me share screen. And then... All right, so I just want to also point out that a lot of the things that Dr. Sanchez was talking about in terms of elevated risk factors and things that lead to cancer are a direct result in the SGM community from lifetimes of coping with stigma and discrimination and being in an adverse place in terms of social acceptability. Typically, in most of my presentations, I do slides on historicity and how we lead to medical mistrust for SGM communities. And we didn't really have time to go into that for this presentation. But I just want to point out that even last week, more than 20 men were arrested for going to Idaho Pride, and they were galvanized by hate speech. This is 1 week ago. So we definitely live in a community still currently where SGM rights and acceptance are variable. We have some rights in terms of same-sex marriage. We have that at the moment, but we don't know how long we'll have that. And it always seems like those are the conditions under which LGBTQ plus people exist. So these are the things that lead to maladaptive coping and can lead to elevated risks for prolonged diseases, including cancer. So that led the NIH to finally get on board and recognize sexual and gender minority communities as a health disparities population for research in 2016. And if we think about that, that was really only 6 years ago. So this is not that long ago. And I know that there were actually a number of people that I've spoken with that really attempted to get NIH to move on this designation for more than 20 years before that actually happened. But it's important to point out that it is acknowledged that SGM communities do have health disparities now. The issue now is funding and how we access funding in order to address those health disparities. 79.1% of all NIH funding goes towards HIV and AIDS. And while that is an extremely important condition that we know we want to invest our research dollars in, it's only one condition. And it really doesn't actually cover all of the health disparities that cover the gamut of people under that kind of banner of sexual and gender minorities. And so it's really important for us to continue to push on against NIH and to to get them to actually fund additional research projects and research studies. The other, as you can see from this list, 39% is for illicit drug use, and then 23.2 for mental health and behavioral health. But those two things often funded in the same study. So that actually is not very representative in terms of the types of studies they're funding for LGBTQ plus research. You can also see real disparities in the populations that are being funded. 86.1 are for gay men, same-sex men, 13.5 for same-sex women, and 6.8 for transgender populations. So we really need to do a better job of trying to access funding to study health disparities across the continuum. So only 6.9% of NIH funding actually goes towards cancer research for sexual and gender minority communities. And I actually did my own reporter search to try to identify where all of this funding was going towards. Even among the 6.9%, some of it is still HIV and AIDS related. The ones that aren't HIV and AIDS related, there are 2 population-based studies for prostate cancer. And then you also have 2 studies for smoking cessation. That is all we have. So it's really important for us to push on this. The fact that we got this R25 funded a second time, and this is the project that I'm about to talk about, is amazing that we got an LGBTQ R25 funded through the NCI. Because really NCI has a history of not funding LGBTQ work. As Dr. Osmond mentioned earlier, I have an R01 on SGM Health under review. And when I was talking to the program officer about where to submit this R01 to, the person who I know very well, who's the program officer, said, you know, Miria, just in all transparency's sake, you know, the NCI doesn't really fund SGM research. We really prefer to fund along race ethnicity lines. And I said, well, I think it's time that we push that and challenge that, don't you? Since LGBTQ people exist within and across all race ethnicities in rural populations and across every other social determining category. And, you know, she got quiet, but we'll see if it gets funded. I mean, the long and short is she was saying it's a long shot. So what the result of this is that there's limited published research on SGM health disparities, and that's where we are. So there's still so much research to be done in these communities in order for us to create SGM health equity. So if you look at this, 80% of the articles are focused on men. They really go right along those categories of where the funding, where the funding is and how we can achieve that. So, and cancer is actually, we're really behind. All of the funding has really been HIV and AIDS and behavioral health at this point. And I would say even the behavioral health stuff is still lagging behind the HIV and AIDS studies. So just if you pull back the lens and look at those kind of funding buckets, that unto itself is stigmatizing. And you have to think, okay, we have to get out of that and start looking at LGBTQ health as, there's been articles published now that says, all research is LGBTQ research. And we really need to start framing it that way. And so that's actually how we started to approach this project. So a group of us came together, Dr. Shine Chang from MD Anderson, Dr. Nelson Sanchez, who you've met, myself and Dr. Irene Tammy Murray, who's at the University of Houston, to write this R25 that would develop a curriculum to train researchers to better work with SGM communities in the area of SGM cancer care. In order to do that, we knew that we needed to have the people who actually wrote the book on SGM cancer. So we convened a national advisory committee of the leading researchers in the area, including Yuli Baumer, and Ronnie Elk, who actually wrote the book on SGM cancer, Liz Margulies from the National LGBTQ Cancer Network, Tanya Poteet, who is just an amazing health disparities researcher, And Quinn, who, if you do any kind of reading on SGM cancer, you'll see Dr. Quinn has published on absolutely everything. And Mandy Pratt-Chapman, Peter Konetsky, and Julian Sanchez, likewise, all very tops in their field. And they have worked really diligently with us to develop the curriculum that makes up the SGM Cancer Care Workshop. So the workshop that we developed for the first 2 years consisted of a number of parts. We had a pre-workshop seminar where people got together, they met with their peers so that when we got to the workshop, we could actually focus on the work that was getting done. So they met, we discussed the goals of the course, the historical context, the gaps in SGM cancer care, ethical concerns of conducting SGM work, which, like working with any minoritized community, are significant. And then also just SGM terminology. We were funded for this right before COVID hit. So while we had planned on conducting the pilot in conjunction with the with BNGAP's LGBTQ workforce conference, we had to move this to a virtual format. So our pilot of this workshop was actually conducted virtually. So while it was fantastic, and I'm really glad we got to do this, it was still kind of double the work. We were thinking, okay, how are we going to make this a functional and engaging workshop in a virtual format? But we pulled it off. So then the workshop itself is actually a 3-day workshop, and it's broken in to really 5 core modules. We broke it into epidemiology, behavioral science and interventions, clinical care, community-based participatory research. And then we had one that was really just about common challenges, and we're reconfiguring that one now. And it's going to be about e-health and SGM communities. So using kind of different ways to engage SGM communities. And then we had interactive exercises and networking. And each of us, the core members of the project team, worked with different subsets of our advisory committee to develop these curricula. And so I worked with Quinn. I know Nelson worked with Dr. Sanchez, and I don't know who else you worked with, Nelson. You're going to have to remind me. But we broke it up. We spent basically a year developing the curriculum for each of these. And we measured success of these by doing pre and post evaluations of each of the workshops. We also brought together, besides allowing everyone to have access to all of these advisors, they had access to different keynotes. We also provided a list of current publications and research journals, and then also strategies for publication and dissemination. So our overall goal, while it was really to teach them how to utilize all of these different research methodologies in the best way to conduct SGM-specific cancer care research, our other goal was also to invest in their professional development. So we really targeted early career investigators who were interested in doing this kind of work. When we did this, we really expected that we would get a lot of people who were actually SGM themselves and kind of thought that that would be our target audience. And we're really pleasantly surprised to discover that we got 50% SGM researchers and 50% who were not, who said, we really want to learn more about this so that we can include SGM populations in our overall research. That's exactly what we want to do, because the only way to really create health equity is to actually increase the number of people who can work effectively with this minoritized population. And I think that it was extremely successful because of that. And so all of our evaluations, we did pre and posts, and then we also did 2 focus groups at the end to see how we could improve what we did. And also what worked for people and what didn't work for people, and just find out what we could do to enhance this experience for people. So we piloted this experience on April 21st, 2021. And our pre and post evaluations demonstrated a marked increase in SGM cancer research knowledge for participants across the board. So on all of it, even people who came in, and we were concerned, we hadn't given this before. So we thought, are we missing people? Are we getting this right? Are we hitting people's SGM knowledge sufficiently? And we've discovered that we were. We have a couple of things that people said we could use a little more kind of remedial knowledge. The challenge to doing a workshop like this is that not everyone's an epidemiologist. Not everyone does behavioral science. So you're creating something that that's teaching people generally. So people will resonate naturally by training in one core or another, but not necessarily. And we had people we had people who were in the medical field, who were doctors or nurses. We had people who were epidemiologists. We had people who were anthropologists. And so we had really a variety of people. The ultimate goal is to create an environment where people can network and conduct collaborative research. You know, one of the primary concerns for SGM research is that it's a small community. So being able to actually develop effective research in one site is sometimes challenging, particularly if you're working with like a transgender community where you have small numbers of people. So working on a multi-site study is much more realistic for people, because then you have larger numbers and comparative numbers. You don't have that if you're working in a single site, and sometimes that really affects your ability to be funded and for people to look at scientific merit. So that's really our not so subversive goal here, is to create these kind of scientific communities where people can actually develop that type of environment where they can work with each other cross-institutionally in order to create more scientifically rigorous projects. And so in the post-workshop focus groups, participants really loved, they thought we had really excellent material and that everything was covered well. They liked the tangible resources that we provided, and that we could show them where they could find SGM-specific information. They liked that we approached this in an interdisciplinary way. We all have a different research background, and they really benefited from that when they were working with all of us. They could tell that we could have these kind of cross-disciplinary conversations and arrive at answers, and I think that was really beneficial for them. And they also got to meet mentors. They also noticed that we handled intersectionality, which is actually a term coined by Kimberly Crenshaw to talk about how African-American women's being African-American and women was multiply marginalizing. And it's something that now we can use for multiple communities as an amazing framework to look at how those things impact people's health and healthcare seeking. But we integrated intersectionality across all of those modules instead of handling it as something that was individual or set aside. Our choice was to do that because it's actually something you can't work with this community without considering that at every level of research development. And so it was a very purposeful frame. And I think it was beneficial for people. They also liked that we had PowerPoint cohesion. Everything that we did, they could look at it and identify based on the banner at the side. Like we had the STM cancer care one here to the right of the slide. We had something similar with a color bar so they could see exactly what we were doing. If it was a resource, if it was something about ethics, they all had their own bar, and they were made aware of that at the beginning of the conference. And then also we helped work with them on their specific aims to help them know how to do that effectively. And so after the 2-year period, we submitted an R25 for a 5-year dissemination award. So we will be able to offer this for 5 years, and we received a really high score. So we're going to get it. I think we're the only R25 that was funded of this 5-year cycle. So we're very excited about it. Hopefully we'll be getting our funding in about a month. So we're looking forward to that in July. And the goal of this is to offer this SGM cancer care workshop annually to 30 early career investigators nationally. And we're going to move this workshop around. So this first year, because it was still kind of, we didn't know what was happening with COVID, we are going to do this first one. Again, we'll do it digital, electronically again. So it will be via Zoom, so people can apply for that. But in 2024, we're going to offer it here at the University of New Mexico, and I really hope everyone applies to have it here. So we'll have it at the Cancer Center here. We'll also offer it in Houston at MD Anderson. We'll offer it at the University of Florida, and then we'll offer it again in New York. So we have plans for 5 more workshops. We also decided we were going to expand it And instead of just having the 3 days with the beginning one, we're also going to incorporate 10 additional 1 to 2 hour topics seminars on things that we felt needed to be drilled into more. And so all of our advisors and then some of our previous participants are asked to actually lead those. And so we're really excited about having the opportunity to expand that. And so this is how we plan to grow and to make this a sustainable R25 for people. So hopefully this will be able to grow and become even larger. So as I said, save the date, spring of 2024 here. We're really looking forward to it. And by then we'll have whatever kinks we have worked out. So it should be really great. And so we also wanted to leave you with some resources to enhance your LGBTQ research where you are now. And I think if you are working in any LGBTQ research, you have to look at the 2011. It was a really important study and publication, The Health of Lesbian, Gay, Bisexual, and Transgender People. You can look this up. It's one of the seminal reports that was published. I mean, we have moved from this initial point, it's been 10 years now, but it really does give a good overview of the disparities in the LGBTQ community. And this organization, which is now NASEM, has actually just published, National Academy of Science, Medicine, and Engineering has just published recommendations on improving our collection of sexual orientation and gender identity data. And the NIH recently submitted an FOA for an administrative supplement to encourage collection of SOGI data at cancer centers. And we actually just submitted that last week. So fingers crossed that we get that, because that will really allow us to enhance our SOGI data collection at the cancer center. And I can tell you from our background information, from our background research we did, we are not doing a fantastic job. So we've proposed to do a lot of work. We have a lot of amazing support from cancer center leadership who have told me that whether we get the grant or not, they want to move forward with this. So we're really excited for the nudge from NASEM and from the NIH for giving us the opportunities to submit this administrative supplement. Another fantastic resource is Healthy People 2030. It gives an overview of what contemporary health disparities are. It's organized by health conditions, health behaviors, populations, setting and systems, and social determinants of health. And they identify 16 objectives and 5 topics. So really, whatever research you're wanting to do, this is a fantastic place to start. There are definitely other reports that you can look into. So I just showed, these are a couple, the SG are the annual reports for the Sexual Gender Minority Research Office, another great report. And for those of you who don't know what the Sexual and Gender Minority Research Office is, it's an office at the NIH. It's led by Dr. Karen Parker, and they help to coordinate SGM health research activities across NIH. They're a great resource to just call and talk to them about them. They don't have their own funding, but their goal really is to kind of nudge other areas of NIH to provide funding that's SGM specific. And I think that Dr. Parker and her team do a great job. And so I will also point out that they have recently published their strategic plan, and that's another place to go if you want to know what's happening right now, and also how they're increasing work in the community. So on that, I'll open it up to any questions you might have, and I thank you for staying with us this whole time.
If anybody has any questions, please unmute, or you can write them in the chat and I will convey them. That was both sort of frustrating information and also enlightening and hopefully empowering. So
yeah, I hope so. It is frustrating. I mean, we feel the same way. And to go to all of these places, we were at the LGBTQ Health Workforce Conference in April, and representatives from the the Sexual and Minority Research Office were there, and we really pushed and said, we need to do something about NCI, and they were like, we know.
On so many levels.
On so many levels. So, we'll keep pushing.
Okay, so Dr. Frankovic says, I note Dr. Sanchez's presentation mentioned that men's health / women's health. This is an observation, not a criticism. There has been recent push from parts of the transgender non-binary community to remove references to binary gender in medicine. There's a proposal to rename the mother-baby unit at our hospital, which has not gone very far. How do we try to be inclusive while maintaining a coherent construct or a common frame of reference for study and description?
Yeah, no, thank you for pointing that out. Yeah, and I'll have to rethink how we present that slide and that information, particularly when talking about sexual minorities. And part of it is you're presenting research that has been collected. So in part, you have to present the data as it was originally collected and presented. So finding a way to be more inclusive, but also being cognizant of how data was originally collected is important. So I'll have to think about how we present that in the future. Do you want to say anything about that, Miria, or add?
Just that's really challenging. I mean, this is a really challenging concern. I mean, it's a large debate about. I don't know. I am not a transgender person, and so I can't speak for, I'm aware of the debate, and I don't have an answer to that or a solution. But yes, I know that in cancer care specifically, there's a big push that mirrors that in terms of provision of breast cancer care. A lot of transgender patients really have kind of a visceral reaction to going into cancer care settings that are all pink and all designed and, skewed towards women's health. And they would like to see, this to be more inclusive of other people who are getting care for breast cancer without it being specifically targeted for girly girl stuff. And I think it's a fair observation. So how you get places to change, it's really challenging. I mean, that's why we've written this R1. We're hoping to address this. It takes a multi-level intervention to do that, at policy, in the environment, and with, training and education for healthcare providers. So I'll say it's a really challenging thing to actually make that type of a change.
Yeah, I think, one thing in terms of recruiting for research, right? If you're recruiting for breast cancer research or prostate cancer research, right? A lot of the materials for prostate cancer refer to men, right? As opposed to people with prostates. Or for breast cancer, a lot of the research protocols, recruitment forms refer to women as opposed to, people at risk for breast cancer, right? So, more work needs to be done, but just being more thoughtful and conscientious, and including SGM identified people, right, on institutional review boards, on research planning committees, to ensure that the protocols and recruitment materials are SGM inclusive is critical.
Yeah, I think that's a really important point. I mean, one of the concerns with the breast cancer initiatives have been that for a while, some people were putting forward that men get breast cancer, but then there was the concern that was a kind of getting rid of the concern that this was primarily a women's issue. And so then it was a gender debate. So that's why I say it's not an easy topic to address, but I think having, as Nelson pointed out, having SGM people on an advisory board helping to shape these things is probably the most important piece.
And how do we do that? you know, we're all busy. These are all things that
Right.
I feel passionate about, but where do you fit in?
Yep. Well, we actually just nominated a genderqueer person who is also a healthcare provider for our UNM Cancer Center Community Advisory Board. So we're very excited to have Tam Simons as the person, and we're really excited to have them. They provide HIV care at Southwest Care Center. And I think, that's how we start. We start by getting, as many people as we can and building capacity for that same reason that you just mentioned. We can't stretch ourselves into every place, even though we try. It's impossible. So I think we have to bring other people in as allies to help us in these different places. And I think we also need to start really considering maybe a community research board. I've been talking to Dr. Andrew Sussman, who leads our Office of Community Outreach and Engagement about this, because I think it is time for us to put together a community, an advisory board of community people touched by cancer, whether they're patients or caregivers, to really provide advice. And it needs to be diverse and represent all of our communities that we serve here in New Mexico.
Yes, agree. Okay, another question. Do you have any resources or recommendations around cancer risk and care for intersex people who represent about 2% of the population?
I'm not an expert in cancer risk for intersex individuals, but I think it's definitely something that we can work on including, particularly for the SGM Cancer Care Project. When I saw the question, I did a quick lit search and I found the citation in PubMed. So I think, we can definitely start there. And I encourage people to look at that citation as well. It's titled Malignancy and Disorders of Sex Development. So I think we definitely need to review it and include it in future presentations. So thank you for pointing that out.
What words do you have for learners and faculty who are concerned focusing their career on SGM health?
I think what I would start off by saying is that there's definitely, in 20 years ago, definitely more than 20 years ago, right? I don't know if people remember Dr. Anonymous or John Fryer, who in the 1970s kind of called out the American Psychiatry Association for including homosexuality listing homosexuality as a mental illness in the DSM manual. But he had to say that wearing a rubber mask and by disguising his voice, right? There was a time when you couldn't be out or conduct LGBT related research in academia, right? And fast forward to now, a lot of progress has been made, right? We have an SGM Health Research Office at the NIH, a lot of faculty, including myself, Dr. Kano, people that she identified that are members of our advisory panel have flourished by being passionate about this work and completing excellent scholarly work in this realm. So I think there's definitely, there's still barriers, still challenges to being successful and being recognized and valued by your peers, but the community is growing. And I definitely encourage you, if you feel like this is something that really interests you and you're passionate about, there are resources and there is a community out there to support you.
Yeah, I totally agree. I think there are challenges. You will get, I've definitely encountered some stigmatizing comments by, older colleagues of mine in particular. And I've had some people say that's not important work. I had someone say specifically, why do you want to work with LGBTQ things? In my experience, they do just fine advocating for themselves. And I said, well, that just goes to show you don't know very much about LGBTQ health disparities now, do you? So, you will encounter people who are really speaking from a place of ignorance, really, from lack of information. And, I just take those things to be like, more, job security, because here's one more person who doesn't know what they're talking about. And, that just keeps motivating me to move forward. But you sometimes do have to have a thicker skin for doing this kind of work, particularly if you're a member of the community. But as Nelson said, there is a growing community of people to support you. And it's really, I think it's amazing to be surrounded by colleagues who are also passionate about what they do.
Yes. Terrific. Well, thank you both for your time in this enlightening discussion. Thank you on behalf of the HSC Office of Diversity, Equity, and Inclusion. Thank you on behalf of me. Oh, there's one more question. As the Cancer Center progresses on the search for a new director, let's make sure specific LGBTQ plus and cancer interview questions are included. I agree.
Yes. I do too.
With that, thank you all. Happy Pride, everyone. Thanks for joining us.
Happy Pride.
If you know someone who missed this, we'll have a recording of it. So tell them to email Amaris or me and we can get the word out. So cheers, everybody.
All right. Happy Pride, everyone.
Happy Pride. Thanks for being here.